Good afternoon and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. November 3rd. Thanks for joining me today. And today we have our roadmap is to talk all things general surgery with Dr. Heather Wakefield. And then I'll give you some updates on the various respiratory illnesses making their way through our community. And some shout outs too. So before we get to that though, I want to bring on Dr. Wakefield. So Dr. Wakefield, there she is. Hi, Dr. Wakefield.
Hi, Dr. Bird. Thanks for having me today.
I'm glad you could join me. So yeah, today we're going to talk all things general surgery. And I think you could handle that, Dr. Wakefield.
Yeah.
Surgeon, that's what she does.
Been doing this for a while, yes.
All right. So yeah, let's get to it. So I'm going to start, and I think this is a good fit too. I really wanted to start with this because both of our general surgeons are women. And so I think that's a great fit for the first topic we're going to talk about, and that is breast cancer. So I just want to start with that, Heather. And the first question is at CGH, where do you fit into the care of a woman once she receives a diagnosis of breast cancer?
Okay. So once a woman is diagnosed with breast cancer, she'll be referred to general surgery clinic. And then from there, we discuss the surgical options with the patient. Sometimes we also see women with abnormal imaging, so they have not had a breast biopsy yet. And if this is the case, we can do the breast biopsy in our office. Most of the time, this is an ultrasound-guided breast biopsy. So if they have a lesion that's palpable, or we can see it on ultrasound, we can do a biopsy. We often do it the same day that they're seen for their consultation so that they don't have time waiting and being anxious. If they have calcifications that are suspicious, then they'll need a stereotactic biopsy, and that will need to be scheduled in the hospital. That is a procedure that I'm also certified in.
Yeah, okay, good. So you just mentioned procedures and stuff that you're certified in. Besides what you just mentioned right now, Dr. Wakefield, what other breast procedures do you perform?
So the most common procedures we do for breast cancer are lumpectomies as well as mastectomies. A lumpectomy removes the breast cancer with some normal tissue around it so that we get what's called a clean margin, leaving no cancer cells behind. And then a mastectomy is removal of the entire breast. We also do excisional breast biopsies for benign disease or for diagnostic purposes if we just need more tissue after a needle biopsy. Also, to check whether the breast cancer has spread to the lymph nodes, we do two procedures for that. One is called a sentinel lymph node biopsy, which is a procedure we use to take out only a few lymph nodes to see if the cancer has spread. In select women who require all the lymph nodes to be removed, we do another procedure called the axillary node dissection. That's a more invasive procedure, but it removes all the lymph nodes that are underneath the arm, draining the breast.
Okay. I want to talk about that. First of all, in the time that I can remember medicine, when I was in medical school till now, it used to be that a lot of ladies would have the axillary node dissection, where they would just take out all the lymph nodes, which sounds good, but your arm has some problems there afterwards, right? So can you kind of talk about how things have improved for women with that?
So breast surgery used to be a lot more invasive, a lot more hard on the patient. They used to do something called a radical mastectomy, which was removing the breast, removing the pectoralis major muscle, and removing all the lymph nodes underneath the arm. Removing the pectoralis muscle, of course, you have problems moving your arm. It's very disfiguring. With removing all of the lymph nodes, one thing that women can get is lymphedema. And no matter what surgical techniques we use, that's just a consequence that can happen. And that's swelling of the arm, which is permanent and very hard to treat other than with physical therapy, massage, and wearing sleeves, compression sleeves.
Yeah.
There's also a couple nerves that run in the armpit that are risk damage during that procedure. So a while ago, they came up with a procedure called a sentinel lymph node biopsy. And the thought was if we could only remove the first couple lymph nodes that are drained by the breast and check those for cancer, we could save women having to have all the lymph nodes removed. So now what we do is the morning of surgery, they'll go down to nuclear medicine. They get a dye injected around the nipple, and that dye travels through the lymphatics to the armpit. And then during surgery, we use a gamma probe, which actually helps us find those lymph nodes. And in this way, we can selectively remove only usually 1 to 3 lymph nodes. And then we send them to pathology, and they check them right then and there with something called a frozen section and let us know if the cancer has spread. And if it hasn't spread, then we can spare them that other bigger, more invasive procedure.
Yeah. Like nowadays, that's almost like the standard of care for how we would get if we needed to look for extra spread beyond the breast.
It is, absolutely. There's other techniques. Another technique that we sometimes do, an adjunct to that, is to put a blue dye in, but it doesn't always travel. So definitely the radio tracer and the lymphoscintigraphy is the standard of care. It's the best method to identify those lymph nodes.
Yeah. Yes. I just want folks to hear that and know that. And that's what we do here at CGH. So, this is a very human enterprise, medicine is, and a diagnosis of breast cancer is, it's one that is filled with anxiety for women. Can you talk a little bit about the conversations how the conversation goes, or what your goal is when you have a conversation with a woman about her diagnosis of breast cancer and what her surgical options are?
Sure. So most patients, when I see them, most of them do have their diagnosis at this point. Our radiology team streamlined things a few years ago. So when patients have an abnormal mammogram or an abnormal ultrasound, they try to do the biopsy the same day or the next day, very quickly get them in to do the biopsy. And then we have a breast navigator, a nurse navigator named Erica, who will often meet with the patients as well as the radiologist, give them the diagnosis. She gives them a big booklet about breast cancer, starts the education process. So by the time they come to me, they sort of have some information already. They have a support team already. Erica will help navigate them through the process. So when they see myself, the first conversation I have with them is the 2 ways to address the breast cancer. And usually it comes down to a choice of lumpectomy, which will also require radiation afterwards, or a mastectomy. And some of that's going to be determined by the size of the tumor, the patient's preference, some of it's their hormone receptors. So we have that discussion first and decide which way they want to go. And then from there, I talk to them about the armpit and checking to see whether it's spread to the lymph nodes like we talked about earlier.
Okay, great. And then for some women who want to go and who require or want to have reconstruction done and those type of things, can you kind of talk through the process of how you get those patients to the appropriate places for that?
Right. So unfortunately here we do not have a plastic surgeon. So patients who want reconstruction or immediate reconstruction, that is not a service that we can offer here at CGH. We can still do the mastectomy here, and there's something called delayed reconstruction. So that's certainly an option that they can have the initial surgery, go through chemotherapy, and do the reconstruction at a later date. But if they do want to have immediate reconstruction or meet with the plastic surgeon up front, then they would need to be referred out. With our geographical location, the most common places we send patients are Rockford or Peoria, or if they really need a tertiary care facility, a university, I tend to send them to University of Iowa because that is where I did my residency. That's where I trained. Some patients also prefer Madison, so that's our other tertiary care facility, a little further away, University of Wisconsin-Madison. So once we have that conversation about, which place they would choose based on transportation, sometimes it's an insurance issue, then my office will make the referral. We send all the pertinent notes, the imaging, the lab reports, and once that facility reviews it, they call the patient and set the appointment for them.
Yeah, good. Okay. I wanted to ask too about, some patients who are going to need to have some sort of treatments with Dr. Ali Khan or Dr. Al Saeed need ports, special access ports for their treatments. Can you talk a little bit about what you and Dr. Kennedy are able to do as far as that goes, and how you coordinate that, I guess, with the oncology?
Yes. So most of our breast cancer patients that we see are going to need to be seen by the oncologist. So we have a very good working relationship with our medical oncologist. If a patient needs a port, the oncology nurse will call our office and talk to our nurses about that. And then we set up the patient, usually within a week, sometimes in a couple of days, depending on how quickly they're starting chemotherapy, to get that port placed. We do not require the patient to come into the office for a consultation, so that saves them a little bit of time and travel, one less doctor's visit for them. The morning of surgery, we'll meet with the patient, explain to them the procedure, the risk, and then they get their port placed.
Yeah, good. And speaking of Dr. Ali Khan and Dr. Al Saeed, and I'll throw Dr. Hatoum, who's the radiation oncologist out at NICTIC. Can you share your perspective on the care that our women who have breast cancer and the treatment that they receive here at CGH and at NICTIC?
Sure. I think the comprehensive care that women get here at CGH is outstanding. Dr. Ali Khan and Dr. Al Saeed are both very fast at getting our patients in once we have done surgery on them. They spend a long time talking to the patient as well as the family about the data of their cancer. They weigh the different pros and cons of each treatment. They educate the patient about possible side effects. And then with the patient's input, they decide on the treatment plan that they're going to use. After a patient has surgery, we follow them for 5 years. So it's not like we just do surgery on them, see them one time, and we never see them again. We see them very closely for 5 years, as well as the medical oncologist during that time. And then after the 5-year mark, we follow them yearly. In regards to Dr. Hatoum, I've heard very positive things about him and his staff out at NICTIC, and he's always available by phone call to discuss difficult cases with.
Yeah, okay. Thank you. And what I want to do now, though, we've talked, I think, all things is related to breast cancer and breast procedures. I want to talk about some other stuff that you do.
Sure.
And in particular, what I wanted to ask you, Dr. Wakefield, was, you know, I think most people, when they think of a general surgeon, they think of someone who's going to take out their appendix or their gallbladder or repair their hernia, which obviously you do all of those all the time.
Yes.
But I want to actually give you an opportunity to kind of talk about some other procedures apart from those bread and butter ones, if you will,
Yeah,
that you do here at CGH.
Yeah, so that's the great thing about being a general surgeon is we really do get to do a little bit of everything. We're not, specialized to the point where we're doing the same couple procedures over and over again. So we do colon resections for colon cancer as well as for diverticulitis. And most of these we can do laparoscopically, which is better for the patients. Laparoscopically means with a camera and small incisions. So they have faster recovery, less pain, smaller incisions, which leads to a lower risk of incisional hernia formation.
Yeah.
We also do skin and soft tissue cases, such as wide local excisions for melanomas, lipoma removal. Some of those can be done right in the office, as well as cyst removals. A lot of people don't know we also do endocrine surgery. So we take care of thyroid and parathyroid pathology. So for thyroids, we follow patients with thyroid nodules. And if the nodule requires a biopsy, that's something that we can do right here in our office. Most thyroid nodules are benign. So 80% of the time, we just follow them with ultrasounds, do a biopsy. But if a patient does require thyroid surgery, that's something that we offer as well, either removing half of the thyroid gland or the entire thyroid gland. Very few cases are so complex that we refer them out to an endocrine surgeon, which are surgeons who specifically specialize in that. Most of them can be taken care of here. We also remove overactive parathyroid glands, which are glands that help regulate calcium. So when patients have an overactive parathyroid gland, what we call primary hyperparathyroidism, this will lead to elevated calcium levels, which in turn can lead to kidney stones, osteoporosis, abdominal complaints, and depression. So if a patient has that problem, we also do those surgeries here. That
surgery is always so interesting. I mean, just these 4 little bitty.
Yes. They're the size, normal ones are the size of a grain of rice, so very small. And even when we say they're overactive and they're enlarged, they're maybe the size of a jelly bean. Yeah. So it can be challenging to find that gland. And something that's recently that we have here is to do what's called a rapid parathyroid hormone. Okay. So when the patient gets to surgery, we check their parathyroid hormone level, and let's say it's 100, so that's elevated. Yeah. We do the surgery, we find the gland that looks enlarged to us and take it out. The parathyroid hormone level drops very quickly. So 5 minutes later, we'll draw their blood and check. And if it's dropped 50%, so we go from 100 to 50, we know we found the appropriate gland.
Right.
So that's very nice as well. That's kind of newer that we have. We used to just take the gland out and hope that there were no other enlarged ones in there. And we would have to wait days because of the send-out lab.
Okay.
So that's a very nice advantage that we have. You get that immediate feedback that you've taken out the correct gland.
Yeah. I didn't know that. That's, I guess if I ever need my parathyroid out, that's good to know.
Yes.
All right, good. Well, great. I appreciate that answer, because between you and I, we've talked here and there about all the different stuff that the general surgeons do that our folks out in the community may not know about. So yeah, I hope folks have a chance just to kind of take that all in and be aware. So if you have melanoma, if you have a thyroid problem, if you have a colon problem or diverticulitis or diverticulosis, all these kind of things are these big, like benign fatty tumors that people will get called lipomas.
Exactly.
Right.
Yes.
Up Dr. Wakefield's alley. So
Yep.
Just keep that in mind. You don't have to go out of the area to get that done. Okay. I keep transitioning on you. The next transition I want to do is, you're the medical director at our wound center. So I can't help but take this opportunity to say kind of what patients would benefit from the services the wound center offers, Dr. Wakefield.
Sure. Yeah, so the wound center is a great resource for patients with chronic non-healing wounds or slow healing wounds. The nice thing is patients don't need a referral to be seen over there, so they can just call up and make an appointment. They don't have to see their primary first. A lot of our patients over there have underlying diseases such as peripheral vascular disease, diabetes, obesity, and this causes them to have delayed wound healing. At the wound center, we look at all of these factors and try to optimize the patient so that they can have better wound healing. Sometimes additional testing is ordered to look at the blood flow to their legs, and sometimes they will be then referred to vascular surgery to see if there's anything we can do to improve that blood flow to their legs to help their wounds heal. We have a whole range of different dressings that we can use, much more than we have over here at my clinic. So we have all of that at our disposal, whether the wound just needs help growing skin on it, or whether the wound needs to have the non-healthy tissue removed before we can put new skin on it. Patients might need a wound vac, which is a great tool we use for larger wounds that help it to heal faster, and less dressing changes, less pain for the patients. We also have 2 hyperbaric oxygen chambers, which are used for select patients who qualify, such as compromised grafts or flaps, crush injuries, delayed radiation injuries, and diabetic foot ulcers that have gone so deep that the bone is infected. So we also have that over there.
Yeah. There's a lot. Yeah. I just wanted to give you an opportunity, because there's a lot of things beyond just like, you think of, I don't know, I have a sore in my foot, and people think, oh yeah, I need to go to the wound center. But there's a lot of stuff that you all can really help people out with. So I just thank you. Appreciate that. Okay. One final question. Any shout outs that you want to give to the folks that you work with here on your team here at CGH?
Absolutely. Surgery is a team effort. Without the support of our nurses in the clinic as well as in the OR, we would not be able to provide the level of care that we do, especially the OR nurses and the CRNAs, who are the nurses that administer anesthesia to the patients. I think a lot of times they often go unrecognized because they only see the patients on the day of surgery. But I'm always hearing when patients come back to my clinic, oh, you have a wonderful team. The nurses were so great. So I just want to recognize them, because I think oftentimes they do not get thanked enough for all the work that they do.
I agree. Well, Dr. Wakefield, appreciate your time and appreciate your expertise. And by the way, Dr. Wakefield has a partner, Dr. Kennedy. If I asked these questions to her, I think she would say about the same thing. So just know that in our area, we have 2 excellent general surgeons who kind of have the full scope of practice and practice very similarly. So yeah, well, Dr. Wakefield, thank you for your time. I'll let you get back to your busy day. And unless there's anything else you wanted to say.
I think that about covers it. Thank you very much, Dr. Bird.
All right. Thank you very much.
All right.
Okay, great. So wanted to take some time now to talk all things respiratory, and then we'll get into some shout outs. So yes, COVID continues to go on. I continue to have some patients here in the hospital with COVID. And like I've been saying for quite a while now, not as many. They don't tend to get quite as sick as they have in the past, although they're still sick enough to be in the hospital and sometimes in our ICU. However, we also are seeing some other respiratory stuff. I'm sure most of you have read about RSV, which is for adults is basically the common cold. But for little people, particularly for infants 6 months of age or less, or pediatric folks who have an underlying condition, like let's say asthma or some chronic disease, it can be a pretty serious thing. So yeah, RSV is definitely out and about in our communities, and anyone who has respiratory kind of symptoms, cough, congestion, cold symptoms, yeah, they could have RSV. They could have COVID. And today I just heard that in our Ready Care clinic, we had our first case of influenza this year. So influenza symptoms are going to be more COVID in nature, in that you typically would have fevers, chills, body aches, and some, upper and lower airway congestion and cough, but they all kind of blend together. So that's why I wouldn't assume that you have one or the other necessarily. I think you need if you need to get out of the house and be around people until your symptoms are far gone, you need to see somebody to figure out what it is. Because RSV, you can be smart about and wear a mask and when you're around people and keep them from getting it. And even the flu in certain respects, you can do that. But COVID is still much more highly contagious than those other two, and you have to have different isolation periods for COVID than for those other two in respiratory diseases. And so I guess the final thing just to say is that, yeah, if you haven't had a chance to get your flu vaccine or your COVID booster, please go ahead and get that done, because that's going to be pretty helpful for you. All right. I think that's all I wanted to say about respiratory conditions, unless other questions pop up for those who are watching right now. Now's the time of the broadcast where I want to do some shout outs. So I'm going to start out with Dinah Rosengren. Dinah is our employee of the month. Congratulations, Dinah. And she's a switchboard operator here and also involved with patient access. So congratulations to Dinah. Yes. Every year we have a jewelry accessory sale in the Ryberg Auditorium. So that's happening, let's see, 17th and 18th of November. So keep that in mind. What else do we have, Rebecca? Oh, yes. So we have a holiday lighting ceremony on November 15th. Every year the hospital is lit up over the holiday season, and we'll do that on November 15th. You'll see the bottom of this. It mentions if you wanted to donate to help with that process with the lights. We're always kind of looking to either add lights or, kind of see where we're at with all that, or replace them if they get old. You can donate. And okay, let's double down on the holidays here. Gift shop at CGH is loaded and ready to go for your holiday ornaments and other decorations. Okay, now it's time to recognize some folks who have their weeks of the year. So this is Sleep Technologist Appreciation Week. So hats off to those folks who do our sleep studies and sleep techs at the hospital. Yes, okay, we want to reach out to Respiratory Care Week is October. Well, it was a little bit back, but we're still saying Happy Respiratory Care Week. What's next? Yes, so radiation technologists. This is Radiation Technology Week, so shout out to them. This is Diabetes Education Week. Big shout out to that group of folks. Our diabetes educators are located in the professional building, which is right above where Ready Care, the floor above where Ready Care is at, and also where Dr. Blasquez and some of his colleagues are at. Okay, I think I've covered everything I want. Is there a third COVID booster available? Mary's asking that. So let's see, Mary. We had the first two. We had a third, and then we have this bivalent right now that is the booster that's available. So right now, I think I lose track of all this, but the most recent booster, which I believe is the fourth different type of COVID shot you can receive, is the one you can get right now. And I'm not sure what's going to go down in terms of in the next 6 to 12 months, if there'll be any further boosters or not. I think part of that will be dependent upon the data that we find out from the current booster, and also what other variants arise and how significant they are, and how susceptible they would be to the current boosters versus any other boosters that may need to be developed. So long answer to your question is I'm not quite sure beyond what we have right now, which is the bivalent, that I'd recommend to go ahead and get if you are in the category of being a fit for it. I think you're good, Mary. If you had the most recent booster, which just came out within the last month or two, you should be all set. Yep, I feel comfortable with that, Mary. Okay. Thanks, Donna. Appreciate that. Appreciate that comment. Yeah, appreciate that too, Donna. Thank you. Thanks for watching. And by the way, thanks to all of you who are our faithful watchers and sharers of this broadcast. We understand that some people aren't able to watch it in real time, but appreciate you sharing it, because what we're trying to do, our goal is to educate and inform the communities that we serve. We do really good things here at CGH, and this is one of the platforms that we have to share that with those communities. So thank you for watching. I hope all of you have a great week. Plan on coming back in a couple weeks. I should have asked Rebecca what date, but I think it's Thursday. Let me just pull this up here. I'm pretty sure it's Thursday the 17th that we're going to be back. And we're going to be talking dementia. We're going to have Dr. Joseph, our neurologist here at CGH, I'm going to be interviewing her and talking about dementia. That's been a main focus of our foundation. So thank you for watching, and we'll see you in a couple weeks. Thanks, Marianne.